It's difficult with the structure of the NHS to identify exactly where you want to place yourself, because your potential buyer, your potential user, your potential beneficiary are all very different people, which could come anywhere across the system. So the layout of the system is difficult to understand for a layperson who hasn't been within it for years and years, and even clinicians who sit within it struggle. We are looking at trying to understand the fact that it is a market, a place, and not a market, which means that you have to find the small niche place and person who has direct interest in what you're doing. And once you've found them, to convince them that what you are doing is worthwhile, will potentially save them money fairly short term, and provide people with a greatly improved experience or some other form of benefit. It requires a great deal of understanding of what they have on their agenda. So you really need to understand what that person's job and function is and what they do on a day-to-day basis, who they report to and what their priorities are, how they're paid, what their incentives are. So you can help support them to drive to their goals, and you can support them to achieve those. It's an indirect consequence of what you're trying to do in the big scheme of things, but you have to work within the framework that you're given. I think a lot of entrepreneurs make the mistake of trying to go in and change the whole system with their product and say, everything else is broken, we just need to start again. It can't happen that way at this time, where pressures are such that everyone is concerned about the pennies that they're going to spend and where they put it, and that the fact that they have to see a return very quickly within 1 or 2 years on whatever they invest in. It's a big problem when trying to understand how to get your product financed and how to fit in within the NHS's financing, because the health economics of how people make decisions differs. You can have two people in neighbouring areas, maybe 20 miles apart, sitting in offices who are looking at exactly the same problem but have different financial restrictions, different reporting mechanisms, different processes for getting things approved, different budgets and different structures with which they work. So the product needs to be customised potentially up to 207 odd times if you're dealing with the commissioning groups, 150 odd times if you're dealing with different trusts, if you're going into the community, another 40 or 50 different organisations, and every single one will differ significantly. So in terms of financing, there is a principle of a business case, and that business case talks about what if we stayed the same and did nothing different. It then says, what if we invested a bit more in doing more of the same? And then the final one is, what if there was an alternative could we invest in, and what's the difference between those three cases? And if you can justify how your different proposition is going to create a new paradigm, but by direct comparison with something that's existing, you're then going to be able to get a case in front of the right people who can make a decision. People who come from an engineering background especially, or from a clinical background, design what clinically fits or what looks great from a practical engineering perspective, but it may be unimplementable, and it isn't necessarily meeting a need that is articulated by the service buyer. And the problem with that is your buyer can't buy something that doesn't fit. So you might have the most beautiful, brilliant innovation that's going to disrupt everything, but your ability to get it taken on board is limited because the person who's buying it can't do it, even if the people who are going to use it love it. There has to be a way of getting this through the door, and the only way of doing that is bringing everyone together around the table, having a discussion, all the clinicians, all the management, all the patients, all the charities, all of the relatives, all the carers, anyone in the community services, anyone in the commissioning, everybody, to go through the process of articulating a need and agreeing that the potential solution or an area of solutions is correct. And once that's defined, you can then start looking at how you can bring your solutions to the table. Starting with building a fully fledged, completely standalone product that isn't able to integrate cannot work. Not because of it being a terrible idea and it being something that will game change everything, but because if you can't get the people who are at the coalface using it, it just will never be used. There are many different reasons why people fail at the implementation. Many people do succeed in getting perhaps a one-off proof of concept, doing a trial of some sort, but it then stops there and doesn't scale. You need to have the right drivers in place, and you need to get people to love you and your product, starting with the people who are going to be using it. So if you go and you co-design something with the right staff and all the right people, even after that you have to be aware that you can't imply to existing services that they're terrible, or greatly ineffective. You can talk about inefficiency, but you need to be able to place what your proposal is in the context of working alongside existing services. Eventually they may well replace them, but they need to start by working alongside them and show that there is an incremental benefit or a significantly drastic benefit at a reduced cost, which delivers greater efficiency. So you have to get in the system and you have to play the game properly, which means going in, befriending everybody, showing the benefit, getting them to buy into the benefit and seeing that it's not really a threat but a complement to what they do, and see where it goes from there. Well, what's very interesting about the NHS is it can be thought of as possibly one of the UK's biggest corporations with a 120 odd billion pound turnover. And when you have a big corporation, there aren't many that you can say are genuinely incredible deliverers of innovation. They are excellent at acquiring innovations and scaling innovations, and that is because they have made a decision that they have a product that works and they're going to take it to market, and they're going to make sure that everyone, anywhere in the world probably, can take that product and it will be the same wherever they are. The NHS is failing to achieve the rollout of innovations because they haven't got any standard products. They haven't got standard processes, they haven't got standard training, they have nothing that's standard across the organisation, which means taking a product and rolling it out just isn't going to be possible. There's no standard way of getting to the coalface. It's a different discussion with 207 people doing the identical job in geographies around the country. And that just is not a sustainable model, which is why in the end commissioning as a part of the NHS is disappearing into a much bigger context around accountable care or integrated care or any other number of acronyms they want to use to define building health economies that are integrated. There's a big issue with trying to learn from international countries and systems and health organisations, because everyone is set up in a different environment where there's a different proportion of public support from the government versus insurance-led support, which is self-paid, and people who self-pay for everything. And then even within the systems that are very similar, you have the health gap in terms of the very wealthy and the very poor. And if you compare a developing country, which has a 20% budget on health versus a fully developed country which has a 10%, with the same system, you have very different operating mechanics. So when it comes to taking the UK and trying to apply an NHS type model and comparing it to anywhere else, it's extremely difficult. You can try and take small bits of learning, but most of these bits of learning are on populations of maybe 50,000 or 100,000 people within a multi-million pound population. There isn't really a system that is scaled to a level which is comparable to what the NHS is. So the Americans try to learn from the NHS by putting in a form of socialised healthcare, as they like to call it, but it's an NHS which just gives them the buyer power to make decisions at scale for a mass market, which makes a lot of sense. And then you go over to Finland, where they have much higher tax rates and various other reasons why they can invest much more heavily, make top-down decision-making because they haven't got the back story that the NHS has, which has evolved over 50 years, came from a very different setup and funding mechanism. The staff are incentivised and paid differently. It's a very difficult thing to just take a learning and apply it. So to my mind, it's about how can we build on the infrastructure that we have to move towards some of these potential models.